folks on now. Thank you everyone so much for joining today. For a net workshop that we have wonderful guests from New York City Health and Hospitals, and they're going to speak to two of their programs, the extended care units and Housing for Health's housing engagement and location services. So really appreciate you all joining. We have this meeting style so folks can kind of be more interactive. But folks, as people are presenting, make sure you're staying on mute, putting questions in the chat, and then, as times are as time permits, raising your hand and engaging and coming off audio that way works as well. I'm joined by my colleague Ashanti Lee at the network. Do you want to say hi, Ashanti?
Hi, everyone. Nice to see you.
With that, just quick intro as to we're here today, and just want to share our speakers from H+H, and then I'll pass it off to them. So we have Fanula Seifert, who's the Senior Director of Housing and Policy and Operations with Housing for Health. We have Patricia Hernandez, Senior Director of Behavioral Health Homeless Initiatives, and Priscilla Swan, Program Director of the Extended Care Unit. And with that, I will pass it off to that wonderful team today.
Thank you so much, Joelle. Thank you, the network, for hosting us. And it's so nice to see some familiar faces. So I'm glad to be in this space. I'm going to start and share my screen, and please let me know if it looks great. Make sure everybody can see it. Let's see. All good?
Looks good.
Perfect. So as Joelle said, I'm Patricia Hernandez, and I work in the Office of Behavioral Health, and I'm responsible for really thinking about our patients who are experiencing homelessness and housing instability, and how can we in the Office of Behavioral Health ensure that our patients who are being discharged from the hospital are coming to our mental health clinics really have all the wraparound services and care that they need in order to survive, to succeed in the community. So today we're going to talk about the extended care unit, which is one of our specialty programs that is excellent. We're having good outcomes from, and hopefully we can expand. And then, as Joelle mentioned, Fanula will talk about Housing for Health. So before we get into it, just wanted to give a little bit of a context of the behavioral health spectrum at H+H. I think oftentimes, I was a person who worked in the community, and I worked in a hospital, and I know sometimes a hospital is a black hole. So just kind of sharing the work we do, what are our services across the continuum. As you can see, we have a high volume of emergency visits, inpatient visits, and that's from our extended care. We have some other specialty inpatient programs like an IDD, so for people with intellectual disability, forensic units. We have a lot of crisis programs, so that includes mobile crisis, Be Heard. We have virtual express care, which I'll also talk about in a second. And then our outpatient programs, which are the addiction services. We have partial hospitalization, intensive outpatient, and the list continues. And really all of that is kind of held through a foundation of our care management, which goes from Health Home Plus, critical time intervention, and complex needs. Oftentimes people say, how do we even access your services? So a couple of things. To access our services for mental health, you have to go through the facility, which can be a pain, but good news, we're going to create what's called a contact center, where there's going to be one number, one intake for all behavioral health services across the hospital. So hopefully that's going to come this fall, which will make things a lot more easier for folks who are trying to access our services. And I'm happy to keep you guys up to date on that and share that information. In the meantime, we also have Express Care, which is our virtual express for people with behavioral health needs. As you can see here, these are some of the conditions that we see. We also, in Express Care, try to connect folks to ongoing mental health treatment. So if somebody is being seen by us, there is an effort to try to connect them into a mental health clinic if that's what they need. Here's some information on that. And I just wanted to take a moment to talk about kind of our work specifically around homelessness. So it's something that we're being much more intentional. Starting last year, we created a strategic plan on homelessness, and it's really us saying that the way we're going to reduce homelessness is to improve behavioral health outcomes through systems change, innovation, and compassionate care. And we're totally housing first, health focused, and patient centered. So, can we support in providing trauma informed, culturally competent care? How do we prioritize permanent housing as a health intervention? So that means, we're trying to move people towards permanent housing, and we have using shelter as an option but not the first option. So how can we at the hospital and behavioral health settings do a little bit more, and making sure our services are patient centered and coordinated. Wanted to just highlight just a couple of programs that are under the Office of Behavioral Health that you may not know about, but these are really like internal programs that we have developed. So the first one is our complex needs program. So as some of you might know who are in OMH licensed housing settings, uh, OMH has defined complex needs by people who are high utilizers, people who have, been in the psychiatric inpatient for over 60 days, kind of a lot of factors, and those flags are being captured in psyches. We're putting those flags in our EHR so that we know when somebody's complex needs, and then we have a complex needs team that will work with the inpatient social workers around discharge planning. So these could be complex discharges from somebody with an intellectual disability needing to be discharged into a permanent setting to somebody who's chronically homeless and has medical issues. So kind of the gamut varies, but we do have this support system in place to support our social workers and discharge planners. We also have in our domestic violence services, we have mental health clinicians that are based in our DV shelters across DHS. So these clinicians provide, from individual therapy to group therapy, and support folks in getting the right connection to community services once they're released from that shelter. We also have critical time intervention, which is a new program that's being launched as we speak. So we're going to have 5 critical time intervention teams. And these are teams that are basically like intensive case management teams that don't provide any clinical services, provide coordination services at time of transition or discharge. And they will be working with our patients. I assume there's probably going to be some overlap with some patients that are maybe going to supportive housing for the first time, or who are in supportive housing but are high risk for us. Like, how do we get this team together to work with a patient for up to 9 months and make sure that they're adhering to their treatment and to their appointments? These teams are especially useful for folks who do not qualify for an ACT team. They could be a good kind of solid point of care management, coordination, intervention. I mentioned before addiction services. We have a bunch of new programs that exist. I was just asking one of my colleagues if I believe there's a booklet out there, and I would love to share that with you guys. So if you do have people in your programs that need addiction services, we have a bunch to offer. So I would be happy to share those. Typo here, but Bridge to Home, you guys might have heard of it. It's our new transitional housing program. We opened a couple of weeks ago, have I think about 6 or 7 patients. And this is a setting where instead of for patients who are being discharged from a behavioral health setting, who don't have any other option but shelter, but are really complex and really high risk, instead of sending them to shelter, they'll come to Bridge to Home, where there are 24-hour services. There's a outpatient Article 31 mental health clinic. And folks there are really being not only treated and stabilized, right? But really help them with independent living skills to make sure that when they move on into permanent housing, they have those skills, they have those connections to the community, and folks can stay there for up to 12 months or more. And then finally, with that, I want to, pass it on to Priscilla to talk about our extended care units. So you guys can hear a little bit more about them, and how to even maybe connect your patients to it, or your tenants to it, or clients. So I'm going to kick it off to Priscilla.
Hey, good morning, everyone. My name is Priscilla Swan, and I'm the program director at the Kings County Hospital Extended Care Unit. So I'm looking forward to presenting to all of you today. So the Extended Care Unit model is a 4-month inpatient psychiatric program that treats individuals with severe mental illness it's a social learning model. So we have groups, we have med management, we have psychotherapy, some of which you might see on an acute inpatient unit. But we have a greater variety of groups, which are used to sort of stress the role of community-based learning. We also do what are called community reintegration exercises, which are basically sort of walk and talk therapy off the grounds of the hospital for those who are eligible to go off unit. So we will truly go into the community with our participants. Again, like I said, for kind of walk and talk therapy, and also for skill building opportunities around budgeting, meal prep, shopping, communication skills, social skills. We also have these behavioral reinforcements. We have a point system to help reward pro-social behaviors. And to help all of these sort of therapeutic interventions, the goal is to kind of help our participants maneuver through different challenges, through stressors, through anxiety-provoking situations, like sort of going into the community quite literally. We also offer really robust case management services. On these extended care units, we are able to help our participants apply for supportive housing, for benefits and entitlements, try to secure vital documents, identification, and really put together very sort of comprehensive discharge plans. And part of the reason we're able to do that is because our units are sort of longer term inpatient units. The average length of stay falls around 100 days, and we're set up to be about a 3 to 4 month program with the flexibility to sort of have people stay longer when needed. So Health and Hospitals operates 3 extended care units. Bellevue's extended care unit opened in March 2020. Kings County, we opened in February 2023, and Elmhurst just opened end of 2024 in December. Next slide, Patricia. So our goals of the extended care units are to reduce psychiatric hospitalizations. One of our criteria is serving individuals who find themselves in a cycle of readmission. So we're looking to interrupt that cycle and hopefully see a shift in that cycle when they leave us. And the other is to secure improved housing for individuals who are experiencing homelessness or whose housing is sort of unstable and supportive. Next slide. So who do we serve? So like I said, we serve adults with severe and persistent mental illness. The most common diagnoses that we treat are schizophrenia, schizoaffective disorder, bipolar disorder. We've also treated people experiencing major depressive disorder with psychotic symptoms. We also treat people who are sort of have comorbid diagnoses of maybe addiction issues, personality disorder traits. So our programs admit people who are on a voluntary legal status or an involuntary legal status. But what is unique about the ECUs is that all of our participants agree to come regardless of their legal status. There has to be some sort of motivation, some yes at the time of interview and admission. Homeless adults are a special population that we serve, but people don't have to be homeless to be eligible for the ECUs. But again, because of what we offer in terms of the heavy support that we offer around housing, a lot of the people that ultimately agree to come to our program are motivated by that goal to finally secure housing. So that is, again, a special population we serve. We accept referrals from acute inpatient units only. So we collaborate closely with hospitals all across the boroughs, both within Health and Hospitals and the private hospitals. And we even have accepted referrals and interviewed people from out in the Long Island, Nassau County, up in, I think, Rockland area, but primarily within the 5 boroughs. Next slide. Next slide, Patricia. Thank you. All right, so some of our inclusion and exclusion criteria. So applicants for the ECU are typically people who they have to be taking medication on their inpatient unit, and they're showing some kind of response. They've landed on a regimen that is working, but they're typically continuing to experience symptoms and would benefit from more time in the hospital. They're folks that are typically already starting to engage in treatment, connecting with staff, maybe going to groups, or we know there's a potential for that. Maybe they're folks who take a while to really come together and leave their room and connect with others, but we see that in their history. And there are also, like I shared, people who have experienced multiple psychiatric admissions in their recent history. There's not an exact amount that they have to have experienced, but we look back in the last couple of years and take a peek. All right, how many times have they been coming in and out of the hospital? What's been going on with them? Exclusion criteria, a diagnosis that might interfere with their ability to kind of participate in the educational programming that we offer. So some sort of neurocognitive disorder, an intellectual disability, a TBI, or sort of a related neurological disorder, that would be exclusionary. If there's antisocial personality traits that are really the driver for their instability in the community, the driver for their admissions, if they're presently displaying violent or overtly sexual behavior that's really disruptive on the acute units. We've certainly worked with people that was a part of their history or even a part of their first week or two on the unit, but in time, as they've achieved some stability and that behavior's reduced, that is absolutely someone we can work with. And then if they have a medical condition, obviously that can't be safely managed outside of like a med psych unit or a medical unit, we wouldn't have capacity to serve someone in that condition. Next slide. So to refer to us, if one of the people you're working with is in a health and hospital facility, super easy. Those facilities put in a consult order for one of our 3 extended care units. We ask them to select one. And then I've included our referral emails for each facility. They send a quick email introducing the team, introducing the patient, what's their current clinical condition, and why might they benefit from the ECU? What do you think they need that we can offer? And then we have a really simple, easy referral portal for anyone outside of health and hospitals. Again, all of our programs offer the same model of care. So when a referring team is trying to determine which facility to refer to, we ask them to consider patient preference regarding borough or facility and whether ECT might be indicated. Bellevue offers ECT, as does Elmhurst. Kings does not. So that might be sort of a major factor to consider. We're also always happy to kind of talk out a potential referral if a referring team has questions. I've talked out potential referrals with outpatient providers, with ACT teams who are questioning if this person might be a good fit and knows that they're in the hospital and is wondering, should we encourage the inpatient team to make a referral to you guys or not? Always happy to sort of talk someone out ahead of time and sort of give the advice, yeah, why don't you go ahead with that referral, or maybe something else would be better. Let's see, I think that might be the last slide, but okay. So my contact information's there. Obviously you have Patricia's. That was sort of a quick and dirty description of the ECUs, but I'm happy to answer any questions, and I'm always happy to talk about the ECUs. So thanks.
Thanks, Priscilla. And we can take time for questions afterwards and have more of a discussion since we're going to have some time. So I'll hand it off next to Fanula.
Hi, guys. I'm Fanula, and I'm the Senior Director at Housing for Health. Next slide. So Housing for Health is H+H's comprehensive initiative to connect patients experiencing homelessness with housing. So in 2024, there was about 80,000 H+H patients who were homeless or marginally housed, and about half of those were also DHS clients, so either in the shelter or known to street outreach. On average, our patients experiencing homelessness will visit the ED 3 times as often. And when they have an inpatient visit, they're staying 4 times longer across their admissions. Housing for Health has a couple of different components to our strategy, and I'm going to focus in on housing navigation services today. But we also operate medical respite beds in partnership with ICL and Communal Life. We fund case management services and affordable housing. So for people who don't qualify for supportive housing but need some additional supports when moving into permanent housing, we offer that in partnership with a couple of CBOs. And we also work to dedicate our land here at H+H to affordable and supportive housing. To date, we've housed about 1,500 patient households, and over half of these patients are housed in supportive housing. And that's a pretty even split between like licensed housing and unlicensed housing. We do aftercare for our patients, and about 99% of those patients remain housed after 1 year. Next slide. So we work really closely with the Metro Plus Housing Task Force, who I think are on this call. And we have looked at the impact of housing on healthcare utilization, looking at a population of about 200 adult patients who are both Metro Plus members and housed by Housing for Health. And across the board, we saw significant reductions in healthcare utilization. So about a 30% reduction in ED visits and inpatient visits, a 36% reduction in length of stay for medical admissions, and a 46% reduction in length of stay for psychiatric admissions. We are planning to kind of studies like this on a regular basis with our patient pool, particularly in partnership with Metro Plus because they are a healthcare plan here. Next slide. So how we work is referrals come from frontline teams across our facilities. So across all of H&H's facilities, we receive referrals typically from social workers and CHWs, but also from clinicians. We work with inpatient units with our primary care SafeNet clinics, which are clinics that serve patients experiencing homelessness at a couple of our facilities, our public health corps, the Metro Plus Housing Task Force, across the offices of behavioral health, also from the ECUs and from our skilled nursing facilities. And there's other kind of touch points throughout the facilities, but I think these are some of the settings where we have our highest volume of referrals. We also do work with DSS on a quarterly basis to match H&H patient pool to like DHS data to identify patients that are homeless and might not be receiving care in one of these touch points, to think about kind of targeting high-risk patients for housing interventions. Those patients are referred to us in a self-built referral system called the GIT. And then we're able to provide them with housing supports through the whole housing process, to eventually place them in supportive, affordable, or market rate housing. Next slide. So our housing navigation work is done in partnership with CBC. We have a housing engagement location and placement services program, which started in 2021, I believe, which provides one-on-one housing support to help patients experiencing homelessness move into permanent housing. Next slide. So we have a couple of HELPS partners. So CBC acts as a hub, and then there's like 4 partners underneath them. There's Catholic Charities, there's SUS, The Bridge, and Welllife. And so these teams work to find permanent housing opportunities for patients, and they really support them through the whole housing placement process. So they'll work in partnership with the shelter or street outreach team to conduct a housing assessment in the fields. They pull together vital and income documents and also supportive housing applications. And they work to coordinate all the various stakeholders to get somebody through the rent-up process. They also will kind of support the patient when they first move in. For like 6 months to 1 year after someone's housed, they continue to outreach that patient and to help kind of resolve issues as needed. They also have some flexibility, like flexible funding to help get supplies and any necessities that the patient needs as they're moving in to make sure they feel comfortable in their new home. Last year, we received about 1,000 referrals to HELPS, and those teams placed over 400 patients in permanent housing. Next slide. In addition to our work with HELPS, I think something that's relevant for this audience is Project ASAP. So this is work supported by the Helmsley Foundation to really focus in at H&H on getting more supportive housing applications done and making sure those supportive housing applications are good quality. I think in the past, often either supportive housing applications like weren't being done at H&H at all, or if they were being done, we were leveraging like existing psychosocials and psych evals that might not be appropriate to send over to a housing provider. And there wasn't a lot of training done to frontline staff on like how to complete a successful supportive housing application. So often those applications were being rejected. People weren't being approved for the right levels of supportive housing. And so we've done a couple of things as part of this initiative in partnership with the Office of Behavioral Health. So we are now training folks across the system on mental health reports. So this is something that HRA is really encouraged, that brings together like a psych eval and a psychosocial and a housing focused clinical document to support a supportive housing application. And these are being done frontline by providers, particularly in the BH settings. And then also we have Virtual Express Care who's able to do those for people who aren't connected to a provider who can do them directly. We're also training care team members across the facilities in how to complete a supportive housing application. And that includes HELPS, does these directly for patients referred to us. And I think a lot of that training has been around like how to translate the mental health report over the supportive housing application. We've made it like very clear, so it's kind of like a copy and paste exercise. And also how to complete homeless verification letters. Because I think in the past we're often kind of like not fully documenting a patient's homeless history, and thus patients were not qualifying for housing programs that they may actually qualify for. And I think that was particularly relevant for patients who often are moving between like shelter and street settings in the hospital. And then HELPS is providing housing search and placement assistance into support housing units in partnership with CUCS and HRA. Next slide. So for any follow-up questions, you can reach out to me. Carlene, who's the director of the Frontline HELPS team, I think is also on this call and is happy to answer any questions. And that's our presentation.
So I'm gonna stop sharing, and as you mentioned, we're happy to share the slide with all the contact information, but happy to open up to any questions or any thoughts that folks might have. Hey, Jordan.
Hey, Patricia. Wait one second. I loved hearing about the voluntary piece and how that, like, everyone who's there, like, has to agree to be there. And I'm just kind of curious to hear more about how that happens for people who have an involuntary situation, or like, I'm wondering also, sorry, my dog, how AOT plays into any of this. And then I actually have one other question, which is it's related but unrelated, and it made me think because my dog. So I'm actually the one who's been doing the Helmsley like individual interviews or like focus groups. And one thing that I've heard about people who've entered into things that may be involuntary or whatever, fears of like, what are they going to do with their pets? And I'm just curious if there's any like planning or things about that to like ease people into like accepting care when they may have like other responsibilities that could be limited from an inpatient, and that may be part of their hesitation. Thanks.
Yeah, that's a great question. I think we interview a lot of people, and not everyone meets criteria. And one of the criteria, right, being the willingness to come, and that is something that we've had people ultimately say no, who otherwise met all our criteria, but said, I just can't commit to this time frame. And we are very open with people when we interview them. We say it's pretty common for people to question, do I want to come? Do I not want to come? And for people to come to the unit and then experience what I call regretsies, and what have I signed up for? And remarkably, even though we're working with people who are experiencing profound psychotic symptoms, there are people, like just last week we interviewed someone she's experiencing a lot of psychotic symptoms right now, but was able to articulate, I'm stuck in a circle. I can't stay in this circle, and I need to do something else. So I think there are people who still find the motivation around breaking either the cycle of admissions or the housing and benefits piece is very motivating when they're housing. If they have housing, it's just not sufficient, or if they're stuck in the shelter. So motivation and legal status are separate things. So a person can be admitted to the hospital, on a 939 or a 2PC. These are different legal involuntary statuses that have to do with the number of providers involved to determine, yes, this person needs to stay in the hospital, regardless of whether they came to the hospital on their own or not. And then there's timeframes connected to that legal status. I will say that I know for at least the Kings County Extended Care Unit, nearly 100% of our patients are on a voluntary status at the time of discharge. I think right now, if I were to look at our patient census, we might have 2 people who are on involuntary status, and the 23 others are involuntary. So although most people are, or I shouldn't say most, although I would say almost half of our participants come to our program on an involuntary status, many of them are converted to voluntary over the course of their admission. So yeah, so the motivation and the legal piece are separate. And again, the legal piece has to do with acuity of symptoms at the time of admission, and sort of how much time you think a person might need to stay in the hospital safely to safely stabilize.
So there's a question about bridge to home that also kind of aligns with the pet question. We get that a lot. Like people don't want to leave their pets, right? And we know that. And it's something actually when we were developing bridge to home, which I'll share a little bit more. Someone asked in the chat to share more. We were really thinking about like, how do we make it a place? Oftentimes the reason people who are chronically homeless don't want to come in is because of their pets. So we're intentionally trying to bring people in, like that's going to be a big thing. We haven't resolved that yet because I think there's so many factors, but what I will say, it's something that's been thought about. And because we're on our first site, like, we're kind of getting our feet wet into what this looks like. But thank you for bringing it up because it is something that's very real and we should be thinking about more collectively. So with that, I'll actually talk a little bit more about Bridge to Home. So, Bridge to Home is a new program that we actually just launched in September. And it was funding that we got the mayor's office when he, at the beginning of the year, gave funding to kind of like homelessness services. And Bridge to Home is a program that is meant to serve people who are coming out of behavioral health settings at health and hospitals who are homeless or at risk of homelessness, have some sort of cycle where they're just not able to do well, right? They're in and out of shelter, they're staying on the street, they're in the hospital, so have some sort of instability. And Bridge to Home would be a place almost like an ECU, but on the outside, where they can go to and live for up to 12 months, receive psychiatric care, group therapy. It's all voluntary. Jordan, to your question, it's voluntary. So people have to agree to be in this setting. And the goal is to stabilize folks. So make sure when they're leaving, they're doing well with their medications, like they're engaged and enrolled in programs that they want to be enrolled and engaged in. They know how to do their laundry. They have entitlements. And then working with the Housing for Health team on placing them into the appropriate housing setting. So this program, the intention is to have at least 2 of them. So the first one has 46 beds and it's located in Manhattan. I don't know the exact address off the top of my head, but it's kind of like near Hudson Yards. So it's there and it's similar to a safe haven, except it's not run through DHS, right? So kind of the philosophy is similar to a safe haven, where it's very low barrier. It's not like, you make a mistake and you're out. That's not the intention of it. The intention is supposed to be a treatment program that really gets you ready for housing. So that's a little bit about Bridge to Home. As I mentioned, there's 46 units now that we have. It's all men. It's an all male facility this time around. Then eventually we have additional funds for another 50, which they're planning on like location, like, is it going to be the same, type of, is it going to include women this time? Kind of thinking about different options there. So that's still on the way. And again, all the referrals can only come from our inpatient side, but similar to kind of the ECU where we already are hearing from ACT teams and other kind of programs who their patients and clients are struggling in shelter, refuse to go to shelter. As long as there's a connection with somebody on the inpatient unit, they're willing to kind of take a look at this patient. And also just to add, similar to the ECU, Bridgestone also has like OTs, right? ECU has OTs, which is really, again, emphasizing that like skills building and those kind of things. Sorry, I'm just looking through the chat.
And I think to the other part of your question, Julia, around people who need a safe place to recover from surgery or like other medical treatment, I agree with the referral to respite. I think this is also something that comes up quite a bit for us. So when patients do need a safe place to recover from medical treatment, we often are like expediting their housing cases to connect them more quickly to housing so that they're able to have those services after. Um, I think those are the major buckets. And our respite program here, the referrals have to come from within H&H, but I know there are other respite programs you can refer people to.
And I know there was a question from Adriana. No, sorry, I saw it somewhere else. Oh, from Taina. Are clients with co-occurring disorders such as substance use eligible for ECUs?
Yes, we've a lot of the folks that we treat are also dealing with addiction and alcoholism. If that is the driving factor for their emergency room visits, for their inpatient treatment, that's usually pretty clear 5 minutes into our interviews with them. And so in that case, we might not be the best fit because we aren't primarily a substance use program, right? We do offer some substance use support and treatment, but primarily we're working with folks where their issue is their SMI. But we absolutely work with many people who have sort of those comorbid diagnoses.
I think the ECUs have been very successful. I mean, I was just looking at data. I think, I don't know, in the last few years, like, I think, Priscilla, you might have sent like one person to shelter, like, since you've been open, like, really successful. People are stabilized and go into permanent housing. So I think we hope to open up more. Elmhurst was our recent one that we just opened up, earlier this year, I believe it was. So, kind of fingers crossed that we can get things at most of our sites. Any other questions or thoughts? Feel free to come off mute. Erica, I see you have how about the substance use component? Are you referring to with the ECU, with another program? Maybe if you can elaborate a little.
Sure. So again, yeah, we work with people who are struggling with substance use. We have, I know at our program at Kings County, one of our staff is a senior rehabilitation counselor and a KSAC. And so there's a weekly virtual 12-step meeting that she sort of facilitates their ability to access and then does like sort of a post-meeting discussion. That's worked into our treatment plans. It can impact the medication management plan and certainly discharge planning. But I would say we're not primarily a substance use program. So when it's evident that that is the primary driver for someone's instability in the community, we would recommend a program that's better suited to address substance use. But yeah, the intersection between people with SMI and addiction is obvious. I think we're all familiar with that. So that is certainly baked into our work. And I see a question about benefits and documentation. And yes, we help apply for SSI, cash assistance, food stamps. A lot of barriers for folks who are homeless is getting the identification that they need to qualify for those benefits. So that's part of our work as well. And I can't say enough about our social work team in terms of both I know at Elmhurst and Bellevue, and then at King's, just the efforts they will make to help people get those vital documents to then qualify for benefits, to then qualify for housing. People are doing tremendous work in the ECUs to really achieve kind of what is very difficult for a lot of people to achieve when they're bouncing around homeless shelters, when they haven't reached a certain level of stability, and then you're navigating a complex system like HRA or Social Security. So there's a lot of work that's done. And again, the gift of time that we have in our program also makes it possible to do that work.
Yeah, when Priscilla mentioned that the average length of stay is about 100 days on the ECU, and our general acute behavioral health units is 21. So if you think about when somebody's getting admitted to a behavioral health, like just general unit, there's not a lot of time to do much. And this is where we're really thinking from our sense, like what are the essential duties of that social worker while somebody has a short, limited time in our inpatient unit to get whatever done, to connect with whomever. But there's really not, unfortunately, not enough time.
And I wanted to add, I know we're talking a lot about the homeless population, but we do also work with people who are already in supportive housing and who simply need more time and treatment. And so, like I said, you don't have to be homeless to qualify for the ECU. Sometimes people just need more time in a structured inpatient setting. And so we'll work closely with their existing supportive housing provider to make sure they maintain that housing and can return. And maybe there's additional supports they need. We've also worked with folks where the housing they were in was just not the right amount of structure anymore. And then we've been able to collaborate on getting them into something with more structure. So again, if you have people in mind, you see them cycling in and out of the hospital, please consider a referral to the ECU and make that recommendation to their inpatient team.
Hello. Hello, everyone. My name is Adrienne Terrio. I'm actually with Commune Life, and I am the Senior Program Director at Woodhall 1 and 2. And I do have some New York Health and Health tenants that are currently in my residence. And I just want to say it's so good to hear the type of services you give to provide for the prospective tenants for myself. So I just wanted to come in a meeting today and just kind of learn what the tenants go through before they're referred to me. And I am so pleased that they go through so much services. So I want to thank each and every one of you for, the amount of work that you do to get them to the point of supportive housing. So thank you. Priscilla, you actually answered my question that I was going to ask, and that is, once they are housed, can EUC still continue to work with the ones that you may need additional services or more intense treatment? So can you elaborate a little bit on that?
Yeah. So if a person's in supportive housing and they get rehospitalized, and oftentimes we'll see people who stabilize pretty well on an acute inpatient unit, well enough to be discharged, and yet they're back again. Sometimes in a matter of weeks, maybe it's a matter of months, and that cycle would suggest that while they look good enough for a discharge from an acute unit, it's not good enough for them to really maintain the gains that they made. And so a longer inpatient treatment in a setting that is the ECUs are calmer settings than an acute unit because, again, the initial acuity has typically been addressed on the acute inpatient units. So our experience, the feedback we've gotten from our participants is that it's a quieter setting. It's easier to sort of settle into therapy. And they also have these longer relationships that they're building with their peers and with the staff. And so there's a real opportunity to help people move further along in their recovery. There's more time to maybe try a new medication regimen, try a new trial of a medication, to do individual therapy work, and then to do some of those independent living skill building by, again, like these community reintegration exercises that we do. They go out with an occupational therapist, with the rehab counselor, with our psychologist. So I think the longer therapeutic opportunities that are available in the ECUs can be really meaningful for everyone we treat, but maybe, especially just for all of them. And that includes people already in supportive housing.
Priscilla, may I add? I think this is also where we can think about, like I mentioned earlier, our critical time intervention teams. So let's say somebody who's kind of been in and out of the hospital, now going to supportive housing for the first time, there might need extra, maybe not clinical support, but more hand-holding. So the goal would be, once those teams are fully kind of launched and working, where like that could be part of their discharge plan, is to get assigned to a critical time intervention team that's going to really ensure that that treatment plan is being followed. They're kind of there to mitigate any risk, work with the supportive housing provider. And again, the idea of critical time intervention is like the first 3 months of a transition are really challenging, right? That's where a lot of things can happen. So they can kind of wrap that patient up, that client, with supports, and make sure that they're doing well, and be also, they have the ability to say, hey, maybe you need to go back to the hospital too. These are CTI programs that are hospital that work with H&H. So they can also get services throughout the hospital. Sorry,
Yeah.
Priscilla, yeah.
Yeah,
Um,
no, I absolutely agree. I mean, I think that's part of the really comprehensive discharge planning that the ECUs try to do, and we'll do that in partnership when there is an existing supportive housing program. And so sometimes that's the more typical ACT and AOT combo that you see, but we have people where we know that they're really getting a lot out of individual therapy, and we think a clinic setting therapy like clinically would benefit them. We pretty much always partner that with a pathway home team, or now with the new CTI teams that are available in health and hospitals, one of those teams, so that they have a lot of those touch points, in-person touch points, on top of their supportive housing, and then on top of their therapy and their provider meetings per month, just to really support them. And so we really try to tailor our discharge planning as much as we can to like what are their specific clinical needs, and at a minimum, we really always try to include a pathway home, or now a CTI team.
just one more thing, and thank you for Patricia, because basically that I just want to let you guys know about my experience working with the tenants coming into supportive housing. What I find is that first 30 days are very critical. Usually, how I prepare my staff is that the first 30 days we may, in some circumstances, we may have relapses. We may have people that decompensate, and it's not because they're not adhering to treatment. It's just that it's a change, and sometimes change is difficult to deal with. So that first 30 days is very critical, because it's scary. It's scary coming from an institution now into supportive housing. So usually the first 30 days you'll see kind of the tenant kind of go down before they get back up, if that makes sense, because of the fact that they're in a new environment, a new change, a lot of fear, a lot of independence for the first time, and a lot of them are institutionalized. So getting out of that whole mental institution, thinking and operation. So um, in my experience, the first 30 days are extremely critical. So if we can have a team that basically, work intensely with the supportive housing for that first 30 days to just provide the support to the tenant. And what I find again is not because they're non-compliant, right? They might stop taking their medication, they might relapse. And it's not because of non-compliance, it's because of the new transition and being in a new environment at times.
Yeah, I think you're absolutely correct. And I think that's why we try to be very thoughtful about the discharge planning, and then also some of the prep work we do in advance of discharge. Like I said, with the community reintegration exercises that we do, I'm thinking of one young man who had been hospitalized so many times, and we got him into supportive housing, and our OT, our occupational therapist, took him to the neighborhood of the housing agency, I think at least 3 times, to walk around the neighborhood, to get familiar with the layout and the commute and the stores and the shops. And just just a little bit of exposure to like his new home environment. And I will say, on top of like the critical time intervention teams, Pathway Home, Health and Hospitals operates the Koskinas program, where we have staff who do follow up patients to sort of check in to see, did they connect to their post-discharge appointments in those first 30 days. And at Kings County, we have a monitoring, referral, and linkage team that's part of that program that will also sort of, if they need to help them reconnect, if they miss an appointment, they need to get it rescheduled. If maybe mobile crisis needs to be called, they're available to operate support. Because yes, those first 30 days are definitely critical.
Any other questions from folks? I also just want to say thank you to everyone who's asked a question. This has been great. And also thank you to our speakers for answering thoroughly. Any other questions? Just want to put one last call out, but I'm seeing, thank yous in the chat. So I want to make sure you all are seeing those and the gratitude expressed. I'll just do one last call for any other questions before we close up. Okay. Is there anything else that the H&H team wanted to share about before we wrap up? Any last things?
I think just feel free to reach out to us. Like, honestly, I think we know how complex the hospital is and how hard, how much hard work you guys do on your end. And these are all our same shared clients, patients. So whatever we can do to support this person going through a very difficult time, I think is imperative to us. So just feel free to reach out if there's questions or ideas or anything like that. And
Thank
Joelle,
you.
I have to update something on the slide, so I'll send that to you so you can send that out to folks.
Perfect. Yes, we will share the slides. We'll share the recording. So that will have all the information that was provided and contact information for you to email these amazing folks. So thank you everyone for spending this time with us, to coming to this NetWorkshop, and thank you again to our presenters. We really, really appreciate it. And yes, we will be in touch soon. And thank you all for joining today.